as has been mentioned, I'm going to restrict to talk about head and neck, face, and orbit vascular malformations, specifically venous and lymphatic. I'm a neurointerventionalist at Ann Arbor, have been there for just over a decade, and have practice spectrum including adult and pediatric neurointervention, including retinoblastomas as well. We have started the program about like 5 years back, and just completed about 100 intra-arterial sessions, as we have heard from our esteemed colleague, Dr. Patsalidis from Sloan Kettering. So moving on. Moving on. So basically, disclosures. I went to medical school in India, so obviously the allegiance to cricket is there. And then I had the urge to pay respect to the Queen. So 13 years I spent in England. So again, the allegiance to cricket remains, and I'm still learning the rules of the game of football. I have some NIH funding, which is both R21s and R01s. So we'll talk about mainly the classification, incidence, and clinical presentation of the specific group of vascular lesions, imaging appearance, and what imaging workup there should be, the treatment technique, which centers basically on use of percutaneous techniques, but other aspects are also there, and we'll look at some case examples. So with classification, as you know, there is the international consortium which met in Melbourne in April of 2014 to come up with this comprehensive classification system, which basically looks at vascular malformations in terms of either vascular tumors or vascular malformations. As you can see here, going back, sorry, how do I go back? Can you go back on the? Oh yeah, thanks. Okay, so basically what I'm trying to say that in the vascular tumors there is these benign, locally aggressive, borderline tumors, and then malignant ones. And then all the vascular malformations are divided into either simple, combined, whether there are major named vessels supplying the lesions, and other associated sort of syndromic abnormalities. So each of these, if you go onto this website, you can click on each of these to drill down into the details of subclassifications. We will restrict our discussion to the lymphatic malformations and the venous malformations. So going ahead, as we see here, vascular malformations class 2A has the lymphatic malformations within it, and principally they are macrocystic, microcystic, and mixed type of lesions, with the septations, which we will see on imaging how they appear. And then there are a host of other syndromic lesions which have individual flavors, including lymphedema, which is classified into a separate classification, which can be associated with multiple other syndromes. And these causal genes that have been identified have been included into the classification system. So going on to the venous malformations, the common venous malformations, the familial type, the globovenous malformations, the cerebral cavernous malformations, and then there are other syndromic varieties that basically complicate how each lesion is viewed. And then we have a combination of all of these. So you can have capillary malformations with venous malformations, capillaries with lymphatics, and all other myriad of different combinations that you can think of. And you can see here that AVMs, sorry, go back one, sorry. AVMs are also included in here. So workup of venous malformations, even if we think they're all venous, one has to look at the dynamic aspects. So cerebral angiography is also involved in the workup of these patients. And that gives us the nuances of what the dynamism of the lesion is and how to tackle those more mixed type of lesions. So venous malformations specifically, the estimated incidence is about 0.01% of them which are congenital. 98% are sporadic. 40% of the venous malformations are present in the head and neck, and pain is related to focal thrombosis. So you can imagine venous malformations located anywhere in the head and neck and the face and orbit and causing symptoms by either thrombosis, pain, proptosis on the eye, vision disturbance because of pressure on the optic nerve, and oral bleeding they can present with. Local compression, as I said, in the orbit is because of space-occupying nature of the lesion. And then you can have diffuse involvement. We'll see some images of this in the parotid gland, larynx, adjacent musculature. And those are very difficult to control. One is thinking about prophylactic tracheostomies, the tongue lesions, which swell up a lot after use of these sclerosant agents. So something to bear in mind. Going on to lymphatic malformations, there is a lot of sort of confusion with older nomenclature as the cystic hygromas and lymphangiomas. They are not technically correct nomenclature, and the ISVA classification includes now all the different nuances of these malformations. The incidence is much more rare in the lymphatic malformation. There are 3 of 100,000 hospital admissions, 50%, more than 50% evident at birth, 80 to 90% manifesting prior to 2 years, and then 75% of these lesions occur in the head and neck. So lymphatic malformations are more common than venous malformations, which appear in the head, neck, face, and the orbit. And they can have episodic changes. So lymphatic malformations are more prone to hemorrhage within it or develop infections. And that way they muster up a pretty significant inflammatory response, causing a lot of pressure effect to adjacent structures. Symptoms are basically secondary to mass effect, and orbit particularly is more commonly involved in lymphatic malformation group. So the workup, as I was alluding to before, involves ultrasound, because these are usually pretty evident on the surface. The oral lesions and the laryngeal or musculature lesions need more MRI imaging to evaluate, but Doppler ultrasound can pick up orbital lesions, nasal, pharyngeal lesions, superficial face lesions. They can evaluate dynamism within flow. So Doppler ultrasound can show you how much of flow there is, how much arterial flow exists within the lesion. MRI obviously is a fantastic imaging modality to evaluate these head and neck face lesions, because they show you all the nuances of how far the extent of the lesion exists under the surface. This is a venous malformation in the angle of the mouth. They tell you the nerves and other important structures that are close to these lesions. When we are treating them with percutaneous sclerosant agents, they can injure these adjacent neural structures. So that is why it is important to map out the extent of these lesions with MRI. MRA is very important because it, again, apart from ultrasound, lesions which you can't see by ultrasound, MRA tells you the dynamism of the lesions, the dynamic MR angiography with sequences like 40 tracks, twist, and other steady state sequences. I'll get on further and show you some case examples. And it's important to have supine and prone MRI, especially in the orbit lesions. So here are some examples where you can see orbital venolymphatic malformation, and it's being treated with percutaneous glue injection and operated. This is a venous malformation in the orbit. Here is a balloon. We basically arrest flow and give bleomycin and other agents which will sclerose the lesion. The imaging appearances on lymphatic malformation is similar on MR. This is basically a microcystic lymphatic malformation. You can see how it's not enhancing. There is patchy enhancement, and these are the post-embolic pictures. So I'll go quicker, and I'll show some case examples here. So this is a 6-year-old with lymphatic malformation with typical appearance on MR, which basically is being treated with bleomycin, and this is a Dyna CT showing contrast and sclerosant material within it. And this is a sagittal image and showing progressive inclusion of the lesion. This is at about 6 weeks, showing complete resolution, near complete resolution of the orbital lesion. And this is the clinical image of that little girl with great response. Some other examples of venous malformations. It's multimodality treatment is the basis. You have to have plastics, ocular specialists, and neurointerventionalists to combine up and to formulate with the most optimal treatment for these patients. Thank you. I'd acknowledge my colleague and mentor at Ann Arbor, Dr. Jamedi. Thanks for your attention.